Very good evening, one and all. Very good evening, fellow doctors. Very good evening, ladies and gentlemen. We've all gathered here today for an academic feast that is to follow from the world of cardiology. As you all know, the ESC updates have just concluded, and a lot of knowledge sharing has occurred from the top cardiologists and the top clinicians all across the world. Just to give the context on the Indian scenario, as each and every one of us know from our clinical practice, India has the second highest rate of CV death in the world, with key modifiable risk factors being a high systolic blood pressure, dietary challenges, a high LDL cholesterol, and even perspectives being diabetes, which is in the foray. We tend to have a clustering of CV risk factors. And as shown in the ICMR InType 17 study, what probably looks as 101 point something million projected diabetic patients, or 136 million projected pre-diabetic patients. What is more important also is the 351 million or 315 million hypertensive patients, and also a very high proportion of patients with dyslipidemia. Why does it pen differently for Indians as taught to us by our different gurus? We tend to have a thin fat phenotype, a clustering of metabolic risk factors. We tend to have atherogenic dyslipidemia, and we tend to develop cardiovascular disease at least 10 years, a decade before our Caucasian brethren. So to throw more light on how the current ESC guidelines can translate to us in the Indian clinical practice, today, on Teachers' Day itself, we have two great teachers in the field of cardiology who need no introduction, but nevertheless, I have the honor of doing the same thing. At the first, I have the honor of introducing Dr. J.C. Mohan, who is the chairman of Institute of Heart and Vascular Diseases, Jaipur Golden Hospital, New Delhi, with over 370 index publications to his credit. He's also been a professor of cardiology at GB Pant Postgraduate Institute of Medical Education, and has also held numerous posts during his rewarding career, has also been awarded numerous awards for the same. Next. We also have, I also have the honor of introducing Dr. Jamshed Dalal sir, who's the director at the Center of Cardiac Sciences, Kokilaben Hospital, Mumbai. He has over 40 years of experience in the field of cardiology, has been a pioneer in interventional cardiology, angiography and angioplasty, and has been an editor of multiple journals and books. He's also the course director and speaker at numerous cardiology conferences all across so many decades. On the same note, without wasting any time, I hand over the session to our first esteemed speaker. Dr. Mohan sir, over to you.
Good evening, ladies and gentlemen, and thank you, Dr. Partha Sarthi, for those kind words, and welcome Dr. Jamshed Dalal, my friend and colleague, who is going to join me in showcasing the highlights of European Society of Cardiology Congress 2023, held in Amsterdam, August 25 to 28, just concluded a week back. A good number of guidelines, new guidelines were issued. There were some focus updates and some path-breaking trials were presented. It is not possible to condense all what has been presented of consequence in 1.5 hours of discussion, which we are going to have. But it is our endeavor, along with Doc Mode, to actually talk about the most prominent observations or most prominent discussions which took place in European Society of Cardiology meeting. So the first part of the story which I am going to discuss is what has been discussed about dyslipidemia in ESC 2023. We know that both inflammation and dyslipidemia are the two broadband markers playing a role in atherothrombosis, and they have a common bridge. When we talk of dyslipidemia, we now know that the focus is on LDL cholesterol, remnant cholesterol, and to some extent on LP little a, for which the randomized outcome trials are going on, and we are waiting for the results with held breath. For inflammation, we actually have very few drugs. The ESC 2023, in its guidelines on acute coronary syndrome, have given 2B recommendation for colchicine for management of post-ACS patients. However, for dyslipidemia or LDL lowering, statins, ezetimibe, and PCSK9-1 inhibitors continue to enjoy what we call as class 1 status. LDL cholesterol is an informative biomarker, is a major risk for atherosclerosis, target is risk dependent, and relative risk reduction relates to absolute LDL reduction. Lower is better. Now we know lower is safer. We have enormous amount of data, both from Fourier, Ole, and from the Odyssey outcome that lower is safer. You can go as low as 15 milligram or even 10 milligram, and still you wouldn't see any adverse effects. This is because there is a consistent, robust, and coherent biological gradient between LDL cholesterol and atherosclerosis, with some exceptions, and there are reasons for those exceptions. We wouldn't go in those details today. Nevertheless, the risk stratification on which the LDL targets are based is same what ESC presented first time in 2019. The ESC 2023 guidelines again emphasize upon risk stratification of all individuals who are prone to atherosclerotic cardiovascular disease. And these patients can be individuals of very high risk. That means those who already have atherosclerotic cardiovascular disease or diabetes of more than 20 years duration, or severe CKD, or familial homozygous or familial heterozygous hypercholesterolemia. High-risk individuals are those who have a risk score. Score actually is the European score, which we don't use in India, but they have validated mostly in Western Europe. And if the score is 5 to 9, diabetes with target organ damage is there, diabetes of more than 10 years duration, moderate CKD. These are individuals who are high risk. Moderate risk is actually individuals with a score risk of 1 to 5, young diabetics and type 2 diabetes below the age of 50 years with less than 10 years duration. Low risk individuals are those who don't have any of these things, and they are the target of LDL has to be less than 116. Now, for very high risk individuals, the LDL target has to be less than 55. For high risk, less than 70. For moderate risk, less than 100 milligram. And for low risk, less than 116 milligram%. We also know that most biological relations like LDL cholesterol and atherosclerotic cardiovascular disease have a floor, and floor keeps lowering with composite risk. As the risk increases, the target actually for LDL target goes down. Now, having said that, what has been re-emphasized in ESC guidelines for management of acute coronary syndrome for secondary prevention? The guidelines have emphasized that the LDL cholesterol should be lowered to less than 55 milligram per deciliter, and along with that, it should at least be more than 50% LDL reduction from baseline. So both these conditions have to be fulfilled. Not only you should achieve LDL below 55, but you should also have more than 50% or more reduction from baseline. Obviously, somebody who has a baseline LDL of 90 milligram, the aim is to get it below 45 and not below 55. That is what the guidelines are trying to emphasize. The guidelines, the 2023 guidelines spearheaded by Robert Byron, also suggests that in recurrent acute coronary syndrome, goal should be less than 40 milligram with a class 2B indication. One more important thing which the guidelines have emphasized is you should initiate high intensity statin therapy as early as possible once you have diagnosed the patient with acute coronary syndrome without even waiting for triage of these patients. And of course, certainly preferably before taking these patients for PCI, you should initiate high intensity statin therapy. So the ESC 2023 sequential approach in post-acute coronary syndrome with targets of less than 55 with 50% reduction or less than 40 milligram with 50% reduction is based on the fact the moment you diagnose a patient with acute coronary syndrome, you have to define the LDL goal based upon the risk, whether the patient has first episode or recurrent episodes. This is done with the help of an expanded lipid profile. Along with lifestyle modification and diet, now within the hospital, as early as possible, high intensity statin therapy needs to be initiated, and that's a class 1A indication. Now, the other interesting part for secondary prophylaxis is that after you have started high intensity statin therapy, you have to look at the lipid profile, expanded lipid profile at 4 to 6 weeks post ACS. And in case you are still not at goal of less than 55 or less than 40, depending upon the type of ACS we have discussed, you have to add ezetimibe 10 milligram a day. This also is a class 1B indication. You again wait for another 4 to 6 weeks. And in case you still haven't achieved target, you have to add PCSK9 inhibitor, either evolocumab or alirocumab in the doses prescribed, and this again is a class 1A indication. However, there is a class 2B indication which gives you some leeway, and the leeway is if you think based upon the baseline LDL cholesterol that this patient is unlikely to achieve with high intensity statin therapy the goal which you have set for the patient, you can initially straight away start with high intensity statin plus ezetimibe, and this has a class 2B recommendation. And in case you still do not achieve the goal after 4 to 6 weeks, then you add PCSK9 inhibitors. So remember, now these guidelines by the European Society of Cardiology for management of post-ACS patients are sequential, with some 2B indication for simultaneous in few patients. By and large, these are sequential, and these give you a time of 8 to 12 weeks before you achieve the goal. Now, during this meeting of ESC, in lunch on symposia, there were plenty of symposia harping on the point that you should strike early and strike hard in acute coronary syndrome patients and try to bring down their LDL cholesterol within days to the target rather than waiting for 8 to 12 weeks as the guidelines suggest. And I would show you what kind of thinking is going on. Maybe that is jumping the gun, but there is some merit in that kind of discussion as well. However, having set those goals for LDL cholesterol, majority of the post-ACS patients all over the world fail to achieve guideline-mandated LDL cholesterol. If you take the US guidelines, which say the LDL cholesterol should be below 70 plus 50% at least reduction, only 50% USA achieve this thing. In China, only 17% people are achieving a goal of attaining LDL less than 70 milligram. You talk of Europe, it varies actually from 23 to 39%. Clearly, vast majority of post-ACS patients are not achieving the guideline mandated goals. And this is a slide which Vijay Kunadian showed during one of the symposia sponsored by Amgen. Now, the strike hard and strike early in ACS were discussed a lot during ECS, ECS meeting, ESC meeting 2023. And the logic given was that if you strike hard and strike early, it will modify the plaque phenotype. It will favorably alter inflammation, immune reaction, coagulation, platelet function, resulting in lower residual risk. And of course, in the long run, there is plaque regression. All these things, there is evidence for all these things available. However, what has been shown already, that in case, even in acute coronary syndrome patients, in case you start high dose statin therapy before PCI, you follow this patient only up to 30 days, you are able to achieve 3-point MACE reduction of as much as 71%. And this is meta-analysis from Italy, where all those trials which have been done giving atorvastatin in post-ACS patients have been clubbed together. Now, this is interesting. Largely, the benefit is because of reduction in peri-procedural myocardial infarction, not in death, not so much in urgent revascularization. The peri-procedural myocardial infarction is brought down by 67% by high-dose statin therapy. And this has been taken in consideration by ESC when it formulated the guidelines for ACS, suggesting that you should initiate high-intensity statin therapy as early as possible once you have diagnosed the patients with acute coronary syndrome. The ESC also relied upon this data again by Patty and colleagues in meta-analysis of 13 small studies in patients who are undergoing PCI and not necessarily those with acute coronary syndrome, again showing a great 56% reduction in 3-point MACE at the end of 30 days. And the benefit actually comes up within the first few days. Within the first week, there is a 44% benefit, indicating that there may be logic in striking hard, striking early in patients with acute coronary syndrome with whatever we have got at our command, rather than trying to achieve goal at 8 to 12 weeks, as the guidelines have enunciated. And the reason again is because post-ACS, there is a vulnerable period for the first few weeks to few months with a gradient which keeps getting lower and lower as time passes. So this is a cartoon showing the risk of major adverse cardiac events plotted against weeks of follow-up. You would see that there is a high risk within the first few weeks, 1 to 3 weeks, and then it tends to go down and probably tends to plateau somewhere around 10 weeks. Now that is interesting because in case ESC is allowing you 10 weeks before you can reach the target, you probably would be missing some of the patients who would develop one or the other major adverse cardiac event during this 10-week period. So hypothesis for LDL lowering therapy hit hard during vulnerable period has a logic. The logic is further proved by another study of ACS called Triton. And here we are looking at actually the placebo-controlled trial, the placebo-controlled events for 3 days following PCI. And in 3 days, the events, 5.6% event occur in those who were on dual antiplatelet therapy, including clopidogrel. What we want to say is that the vulnerable period is not only controlled by high-intensity P2Y12 inhibitors, which Dr. Jamshed Dalal would be talking, but also by high-intensity statin therapy and other LDL-lowering therapy. So if you look at 8 months, 6 months, and 12 months, within 3 days, the major adverse events are nearly 6%, but at the end of 1 year, they are 12%. So for next actually 360 days, only an additional 6% events take place. That tells you the importance of lowering LDL cholesterol within first few days of acute coronary syndrome. This has also, so we have now a way of lowering LDL cholesterol within days, and this is an interesting study published just 2 years back called EVAC, where evolocumab has been given as a single injection in patients the moment they have been admitted with acute coronary syndrome and first blood sample has been drawn. This is 420 milligram of evolocumab given, and you would note that the lower curve, which is for evolocumab, and the upper curve, which is for placebo, within 3 days, you find a remarkable, statistically significant lowering of LDL cholesterol with evolocumab. And at discharge time, which is about 4 to 5 days, you see that the LDL cholesterol is more than 60% lower in those individuals who have been given evolocumab compared to those who are on high-intensity statin therapy. Of course, at the end of 30 days also, now that was a single injection, you would note that the LDL cholesterol with evolocumab arm slightly rises, with high intensity slightly falls, because statins work slowly. Evolocumab works much faster within hours and days, as shown in EVAC study. And it has been proposed by those who say that strike early and strike hard, that you should start these monoclonal antibodies against PCSK9 right in hospital as early as possible in patients with acute coronary syndrome. The data, actually, this kind of logic is also supported by another study called EVOPAX, wherein actually in statin naive patient, in EVAX, these patients, majority of these patients were already on statin before they developed ACS. Here are majority of the patients are statin naive. So they have a baseline LDL cholesterol, something like 139 milligram. And with evolocumab injection given every 4 weeks at day 0, day and 4 week and 8 week, you would find a remarkable reduction in LDL cholesterol of 77% at 8 weeks and nearly same 75% at 4 weeks, clearly indicating that in case you want to decrease the residual risk, which is there present in the first few days and first few weeks, you would have to use something which will strike hard like evolocumab. The study also talks about prove-it data where within 30 days also there is a remarkable difference between the atorvastatin 80 milligram and pravastatin, again indicating that in case you cannot use these powerful drugs, at least high-intensity statin therapy given as early as possible compared to modest LDL lowering therapy proves beneficial in post-ACS patients. So far, what I have talked is that in ESC 2023 guidelines, the hit early and hit hard with LDL lowering therapy is unique and tantalizing concept in acute coronary syndrome. ESC did not go along all the way in absence of outcome data. Remember, this is just a surrogate. You don't have outcome data. We believe outcome data will be positive, but till the outcome data comes, ESC has given a sequential way of lowering LDL in 8 to 12 weeks to the target. The approach of LDL lowering therapy is still sequential in ESC 2023 guidelines, giving 3 months time to achieve the LDL goal. Question is, should we jump the gun and try to give triple dot double therapy or even monoclonal antibodies in whichever form? I think it is wise to wait for the outcome data. However, there seems logic for those individuals who are using this sledgehammer approach. The few other studies which were presented with regard to LDL cholesterol lowering, one of the study was called Lodestar. This study is from Yonsei University Hospital, Seoul, Korea, And this is an interesting study of 4,400 patients where rosuvastatin has been compared with atorvastatin in secondary prophylaxis of coronary artery disease. Of course, we have been using these drugs interchangeably. Sometimes we use rosuvastatin, sometimes atorvastatin. However, the pharmaceutical environment has always been talking about superiority of one over other. Rosuvastatin is hydrophilic, but more potent. Atorvastatin is lipophilic and slightly less potent. However, now look at 4-point MACE, which is death, MI, stroke, and urgent revascularization at the end of 3 years with rosuvastatin versus atorvastatin, wherein nearly 70% patients were on high-intensity statin therapy. You find no difference between rosuvastatin and atorvastatin with regard to 4-point MACE. With rosuvastatin, the end LDL target achieved was less than 70 was achieved in 62%, with atorvastatin in 55%. Obviously, rosuvastatin was more potent, but the interesting part of the story is that when you look at 4-point MACE, they were not very different between rosuvastatin and atorvastatin. The two fly in the ointment was there were more new onset diabetes with rosuvastatin, and there were more cataracts with rosuvastatin. And we don't know whether these are of practical significance and how much significant they are when we are dealing with secondary prophylaxis of coronary artery disease. Another lodestar study presented by the same group talked about giving a sledgehammer approach with high intensity statin without even bothering about where the LDL cholesterol goes on follow-up versus treat to target, wherein the statin therapy is tailored to keep the LDL between 50 and 70 milligram, was tested in a randomized manner, again in these 4,400 patients. Remember, this is a 2x2 factorial design study, so it is able to give two answers. With one study, you are trying to give answer to two queries, and herein it has been shown that whether you use high-intensity statin therapy, which means 20 to 40 milligram rosuvastatin or 40 to 80 milligram atorvastatin, without even looking at LDL cholesterol, or you try to actually give these drugs and then keep measuring LDL till you come within that range of 50 to 70 milligram, 4-point MACE are no different whether you use a sledgehammer approach or repeatedly check LDL cholesterol level and do it what is called treat to target. Obviously, there are economic implications of this study, but this study also tells you that 2013 guidelines, ACCHA guidelines, probably were valid, that you could actually give one of the two drugs at the highest tolerated dose in patients with coronary artery disease without measuring LDL cholesterol at baseline or in follow-up. But what we need to understand actually is that when you use treat to target, you will up titrate, you will down titrate based upon the LDL level, and this will entail frequent visits and more cost. And you need to keep that thing in mind. Another important study which was presented in ESC was Ocean A dose extension study. Now, Ocean A dose study was presented by Michelle Donahue from Harvard Medical School in AHA 2022. And this is an extension study for 1 year. The olpasiran, which is a small interfering RNA molecule, which actually which decreases the LP little a as much as 95% when given every 12 weeks in a dose of 75 milligram or more. The 95% reduction LP little a was shown in Ocean A dose study. When the study was terminated, these patients were followed for 1 year. And in this open label follow-up, when no olpasiran was given to these individuals, people who were given olpasiran still had as much as 50% lower LP little a after 1 year compared to those who were not given olpasiran, clearly indicating long-term persistent benefits of olpasiran. The question is, should we lower Lp(a)? And that question will be answered by another study called Horizon, which is being conducted by Pella Carson, and we expect the results somewhere in the end of 2024 or maybe in the beginning of 2025, unless, of course, another catastrophe like COVID comes and the results are delayed. But Lp(a) is a potential therapeutic target, so it is necessary to understand what is going on in the field of Lp(a), which represents a residual atherosclerotic cardiovascular risk in patients where the LDL goal has already been achieved. The second part of my talk is about heart failure studies in ESC 2023. Good part of this would be discussed by Dr. Jamie Dalal. I will tell you what some of the salient things. One of the important things which has been discussed in this study and which is there in guidelines is iron deficiency and heart failure. Why is it important? Now, iron deficiency is an important clinically meaningful comorbidity which is under-recognized, under-appreciated, and under-treated. Iron deficient heart failure occurs in 50% of all patients. There are multiple mechanisms by which iron deficiency occurs, right from poor dietary absorption to renal disease, blood loss because of antiplatelet therapy, impaired release kinetics, reduced gut absorption due to hepcidin, and of course inflammation. Multiple things play a role in causing iron deficiency, which occurs in 50% patients with heart failure, and this is associated with reduced functional capacity, recurrent hospitalization, and increased mortality. The iron deficiency in heart failure has been defined in absolute, functional absolute when the serum ferritin level is less than 100 nanogram per ml, and functional when the serum ferritin between 100 to 299 plus transferrin saturation less than 20. The new 2023 ESC guidelines, and this needs to be emphasized, give a class 1A recommendation for IV iron supplementation in patients with HFrEF or heart failure with mildly reduced ejection fraction, those who have iron deficiency, to improve symptoms of heart failure and quality of life. Choosing between ferric carboxymaltose or ferric deriosmomaltose, isomaltose, it is a class 2A indication, which means you can use any of the two. There's more data with FCM than with FDM, but the guidelines have upgraded iron supplementation class 1A therapy. What was there in 2021? 2021, it was 2A. So ferric carboxymaltose in those with iron deficiency with heart failure was a class 2A recommendation, which has been moved to class 1A recommendation. Why? Because there have been a large number of trials with IV iron heart failure, starting from FAIR-HF by Stephen Anker, CONFIRM-HF by Peter Pinokowski, and then of course we had last year two big trials were presented, AFFIRM-AHF and Ironman study. Ironman study was presented by Paul Colra in AHA 2022, and in this ESC 2023 heart FID study was presented by Dr. Robert Mentz, and this is an interesting study. I think you need to get a little bit idea about heart FID study. But before heart FID study, meta-analysis of all the studies using IV iron in heart failure showed that, and this meta-analysis includes AFFIRM-AHF and Ironman study also, suggests that the hospital for heart failure and cardiovascular death is reduced by 23% by use of IV iron, those who are iron deficient, and hospital for heart failure reduced by 28% compared to placebo. Another meta-analysis, which actually included some more studies, showed a similar kind of results, but it showed that IV iron supplementation does not affect all-cause death or cardiovascular death. And this is something which we need to understand, and you would be surprised why this drug has a class 1A indication in new ESC 2023 focused update. Now let us come to the presentation which was done in this ESC 2023 called Heart FID study. Largest study, 3,065 patients of HFrEF were enrolled in this double-blind multi-center trial. After a 28-day screening period, participants were stratified by region and randomized to 1-to-1 ratio to receive either IV ferric carboxymaltose or a placebo for treatment. This is the design of the study. So all these patients had injection fraction less than 40% with iron deficiency defined by the usual criteria. And the primary endpoint was all-cause mortality, heart failure, hospitalization, change in 6-minute walk time. Now, the dose given was 15 milligram per kg of body weight, 2 doses, 7 days apart. And then the point was that there was replenishment done actually once every 3 months, and dosing visits for every 3 months, and dosing was done every 6 months as needed based upon the values of the plasma. Now, this study showed a cardiovascular death and hospital heart failure reduction of only -6%. The p-value was 0.019, which did not reach the pre-specified p-value of 0.01 as was determined by FDA. However, there were trend in favor. All-cause mortality was decreased by 16%, total hospitalization decreased by 11%, and there was a 4-meter increase in 6-minute walk time with ferric carboxymaltose in these individuals. So far, so now the intravenous iron has a class 1A indication in heart failure, but iron deficiency in heart failure, evidence for adverse prognosis is strong, but evidence for impact on modulating iron deficiency is mild to moderate. Mild when you look at the heart FID study, moderate when you look at the AFFIRM AHF study, and you also look at the Ironman study by Paul Colra. Question is, does IV iron studies justify class 1A recommendation? And this will be a question to be debated, and we will wait for the ACC/AHA focus update in 2023 or 2024 to find out how the Americans think about it. But remember, replenishment has to be a continuous process because iron deficiency leads to heart failure and heart failure leads to iron deficiency. Focus update on heart failure did talk about HFpEF, and now you have 3 things in class 1A therapy for HFpEF, which Dr. Jimmy Dalal will talk in detail: SGLT2 inhibitors, diuretics for fluid retention, and management of comorbidities. Similarly, focus update for heart failure with mildly reduced ejection fraction talks about 2 class 1A therapies, SGLT1 and diuretics, and of course 2B for MRA, beta blockers, ARNI, ACE inhibitors, and ARB. The interesting part which is there in these guidelines, focus update, is based on strong HF study, and this is class 1B indication suggests that intensive strategy of initiation, rapid up titration of evidence-based treatment before discharge and during frequent and careful follow-up within the first 6 weeks following heart failure hospitalization recommended to reduce the risk of heart failure hospitalization and death. What it says is that once the patient has been discharged with a diagnosis of heart failure from hospital, try to get all the 4 drugs on board and try to get all these 4 blood drugs within 6 weeks at the maximum tolerated dose. And this data is based on strong HF, and you know that strong HF data did show a 34% reduction by intensive therapy, wherein up titration was completed within 2 weeks, although it did not affect mortality, as you can see on the right part of the graph. The other part of the story, which I'll take 1 minute, is the prevention of heart failure and diabetic kidney disease. The SGLT2 inhibitors and finerenone both have a class 1A recommendation, and this finerenone now actually has a newer indication in patients with diabetic kidney disease. Last part, etiology-specific HFpEF, heart failure mid-range ejection fraction therapy. New data is there in the form of attribute CMA study, and this study has used actually acoramidis actually rather than tafamidis. The previous trial attract was with tafamidis in patients with ATTR amyloidosis presenting with HFpEF. This is with acoramidis, and ATTR, the ATTRACT trial with tafamidis did show a decrease in all-cause death, significant decrease in 30% reduction in all-cause death and hospitalized for heart failure. Attribute CMA, which has used acoramidis, actually has 800 milligram twice a day of acoramidis, and compared to placebo in individuals who have typical HFpEF, and they have used a win ratio. The win ratio is 1.77 in favor of acoramidis, again indicating that now we have another molecule to give competition to tafamidis, and hopefully because of this competition, the costs would come down, and 10% of all patients with HFpEF actually may have ATTR amyloidosis, and we might find light at the end of the tunnel. So the attribute CM all-cause mortality was reduced by nearly 25%, and the curve started separating at 19 months. The cardiovascular mortality reduction was 30%, with the number needed to treat being 16. Again, very impressive. There was reduction in NT-proBNP and improvement in 6 months walk time, improvement in the KCC overall score, and of course, improvement, more decrease actually in the serum TTR, all were seen. The improvement in baseline NT-proBNP and the improvement in 6-minute walk time are very impressive with the acoramidis. And so what we can say is ATTR, there is now rapidly expanding therapy. We have biologics like patisiran, inotersen, and we have TTR stabilizer like tafamidis and acoramidis. To summary, ladies and gentlemen, in atherosclerotic cardiovascular disease, LDL cholesterol and other particles containing cholesterol cargo are the focus of attention. The heart failure is a rapidly expanding field due to its epidemic proportions, and new focus update about ESC talks about this in great detail. And ATTR has become an area of great interest, and we have a new drug to treat elderly HFpEF patients with ATTR with the surprisingly good results, which will give competition to tafamidis. Thank you very much.
Thank you very much, sir. We now hand over the session to Dr. Dalal, sir, for his oration.
Thank you.
Dr. Dalal, over to you.
Thank you, Dr. Mohan, for a wonderful discussion on so many interesting topics presented at the ESC. I think there was a great amount of learning from your presentation. I'm also going to cover a few topics related to certain aspects of cardiology. Obviously, the ESC meeting was too large to cover completely in an hour's time. A few words about the de-escalation therapy in patients undergoing PCI. Now, in the past, we used to, of course, start patients with aspirin and clopidogrel and then continue with the therapy. When prasugrel ticagrelor came into being, we started shifting some of our patients from clopidogrel to ticagrelor or prasugrel, and then we continued that unless they had a major bleeding, and then we de-escalated the therapy. But now there is emerging a thought process of looking at these patients more individually, looking at their bleeding risk versus their thrombotic risk, and optimizing treatment individually depending on the patient's problems. Now, if you look at this chart, it sort of quite clearly explains to you after the index ACS PCI, normally we have two options. One is we continue with both aspirin, which is shown in yellow, and a potent P2Y, which could be either clopidogrel, prasugrel, or ticagrelor, and we continue this both for a period of 1 year, and then at the end of 1 year, we make a decision of what needs to be done next. Secondly, and which is often followed in our country, is that we continue aspirin for a full 1 year, and then we use ticagrelor or prasugrel for a short period, maybe 1 month to 3 months, and then shift over to clopidogrel. And this is what many of us have been doing in the past. Now, of course, there's a lot of push about losing an abbreviation of the DAP. For example, you continue aspirin for 12 months, but you reduce the use of ticagrelor for a period of 3 to 6 months. And more important now, there is the push towards stopping aspirin as soon as possible. So the latest push is more towards stopping aspirin within the first 1 to 3 months, again, depending on the patient's bleeding risk versus the thrombotic risk. Obviously, the higher the bleeding risk, the more the need to stop aspirin early. And of course, if you stop aspirin at either 1 month or 3 months, it's important that you continue with clopidogrel, prasugrel, or ticagrelor for the next period of 1 year. And again, between that, you may decide if the patient's a very high bleeding risk to use clopidogrel rather than ticagrelor. So individualization of treatment is the way for de-escalation of DAP therapy following ACS. So that's important. Remember, it's not a one protocol for every patient. Then, of course, you must also remember that at the end of 1 year, you still have to make a decision of what needs to be done. So you have multiple options. You have a class 1 option, of course, is aspirin monotherapy to continue. And this is a good therapy to use in patients, especially those who have high bleeding risk where you don't want to use dual antiplatelet therapy. Then, of course, you have two other options. If the patients are high risk for cardiovascular events, then you can either think of a dual antiplatelet therapy, which would be aspirin plus clopidogrel, or a reduced dose of ticagrelor 60 milligrams twice a day. Or if the patient falls into the COMPASS group with multiple peripheral vascular disease or stroke in addition to coronary artery disease, you could think of using a vascular dose of rivaroxaban 2.5 milligrams along with aspirin. And then, of course, you could also use a P2Y monotherapy, which is continuing either a low dose ticagrelor 60 milligrams twice a day or clopidogrel long term. As you well know, there's a lot of discussion and studies going on between whether we should use aspirin or whether you should use clopidogrel long term as a single antiplatelet therapy. And there is more and more growing evidence to suggest that it may be better to use clopidogrel as a monotherapy rather than aspirin. Now, for years, we have been using aspirin when we choose one antiplatelets in the long term, but it's their suggestion now that probably clopidogrel is better in terms of equal efficacy or in fact better efficacy and much less bleeding compared to aspirin. So those are the points that we need to keep in mind as far as the ACS antiplatelet therapy is concerned. A quick word now about endocarditis. Endocarditis continues to remain a problem. We occasionally and off and on see these patients. And again, you know, the portal of entry could be oral skin infections, direct inoculation, and healthcare exposure. And again, treatment depends on what risk profile that you fall into. Of course, as far as the antibiotic prophylaxis is concerned, the class 1 indication level B is anti-prophylaxis recommendation for dental extractions, oral surgical procedures, and anything which requires gingival manipulation. And of course, systemic antibiotic prophylaxis may be considered as a 2B recommendation for patients undergoing therapeutic procedures like endoscopy, bronchoscopy, genitourinary or skin procedures. So yes, prophylaxis of is important and class 1 indication for dental prophylaxis. A more complex chart looking at the various indications. If we look at class 1 indications, then general preventive measures. So that's very important, the general preventive measures. Antibiotic prophylaxis, as I mentioned, also for patients with ventricular assist devices is class 1 indication. And heart transplant patients prophylaxis is class 2B. Again, patients with high risk for developing endocarditis should have prophylaxis for any of this gastric, genitourinary, or respiratory interventions. And again, importance of transesophageal echocardiography, and we know how important it is rather than simply going for a chest for regular echocardiography, again, a class 1B indication. If you move further, the prophylactic antibiotic regime for high-risk dental procedures, if we simply look at the adult population, then no allergy to penicillin or ampicillin. The simplest would be amoxicillin 2 grams orally 30 to 60 minutes before the procedure. So I think it's important to make a note of this. And whenever you have patients with valvular disease, it's well worth noting and giving instructions that antibiotic like amoxicillin 2 grams orally to be given 30 to 60 minutes. You know well that many doctors prescribe it for 2 days before, etc. And I think it's important to remember just prior to the procedure is important. And if you cannot take orally, need to give IV, then of course ampicillin and of course cefazolin is also possible. Those who are allergic to penicillin and ampicillin, you can use cephalexin or orally or azithromycin, clarithromycin, and even doxycycline. So these are the recommendations for prophylaxis for endocarditis for patients undergoing procedures. Of course, once you get endocarditis, I think you're well aware of this. You need to define endocarditis. You have 2 major criteria. One would be positive blood culture. Second would be a positive imaging. And then you would need either 1 major criteria with 3 minor or 5 minor. And if you look at the minor criteria, the predisposing condition to developing endocarditis, fever as a second minor criteria, embolic episode as a third criteria, immunological phenomena like Osler's nodes, glomerulonephritis, and microbiological like positive culture serological evidence. So clearly these are the guidelines which are more or less consistent with what we have been doing in the past. And then, of course, we're talking of treatment of effective endocarditis. You have the very critical early phase, which is the first couple of weeks. in which case there's an inpatient treatment with rapid IV bactericidal combinations. Cardiac surgery is very important to be done earlier, especially if there's infected valves or draining abscesses, or if you got a device put in which has got infected. So do not forget the surgical removal of the infected source. And then, of course, continued the treatment, which may go from 2 weeks onwards to 4 to 6 weeks. Complicated cases continue inpatient IV treatment. Otherwise, you can perform a transesophageal echocardiography at day 2, at day 10, class 1 indication, before you switch therapies to make sure your treatment has been good. And from day 10 post onwards, you can continue management of these patients on oral drug therapy, antibiotic therapy from home. So some sort of a guideline as to importance of early IV therapy, the importance of surgical intervention, the importance of transesophageal echocardiography before shifting from IV to oral and sending the patients home. Now, again, moving to heart failure, Dr. Mohan has already spoken about heart failure, and it's a subject which has been discussed in great details even in the past ESC meetings. There are two, as far as patients with mid-range or mildly reduced ejection fraction, as it is not now called, which is an important criteria, subset of patients that we see with heart failure. Because we don't always see patients with heart failure with ejection fractions of less than 35 to 40, but we do see a fairly large number of patients with EFs of 40, 45, 50, and what do we do for them is an important aspect of treatment. So the class 1 indication, of course, is diuretics is required. And again, most important, class 1 indication for mildly reduced ejection fraction is either dapagliflozin or empagliflozin. So that is moved into class 1 indication. ARNI, of course, which we all use anyway, is a class 2B indication, mainly related to the fact that SGLT2 has large number of studies looking at various different groups of heart failures, whereas there's a much less data in terms of large studies with ARNI. MRAs continue to be class 2B and beta blockers class 2B. This is, please remember, for mid-range or mildly reduced ejection fraction, not for reduced ejection fraction per se. And when you talk of patients with preserved ejection fraction, which is again getting a lot of importance, and Dr. Mohan mentioned about looking at the comorbidities of this patient. So what are the class 1 treatment indications for preserved ejection fraction? Diuretics, of course, for symptomatic treatment, but look here again. Class 1 indication for DAPA and empagliflozin for heart failure with preserved ejection fraction. And of course, most important, treatment of the etiological factors, both cardiovascular and non-cardiovascular comorbidities, as a class 1 indication. So dapagliflozin now seems to have moved into a class 1 indication for heart failure with reduced ejection fraction, heart failure with mid-range ejection fraction or mildly reduced ejection fraction, and heart failure with preserved ejection fraction as well. So if you look again in the diagrammatic way, recommendation for treatment of patients with symptomatic failure with mildly reduced ejection fraction, SGLT2, and they've not mentioned canagliflozin, only DAPA and empagliflozin because of the much greater data for these two drugs, class 1A indication. Recommendation for treatment of patients with symptomatic heart failure with preserved ejection fraction, again, DAPA, heart failure to reduce CV death, and hospital class 1A indication. Then if we look at the recommendations for pre-discharge and early post-discharge follow-up of patients, what they suggest, class 1B indication is an intensive strategy of initiation, rapid uptitration of evidence-based therapy to reduce heart failure hospitalization as death. So early use, pre-discharge or very early post-discharge, all forms of heart failure treatment as mentioned earlier, including SGLT2 for the full range of heart failure patients. Recommendation of treatment for prevention of heart failure in patients with type 2 diabetes and kidney disease. That is, this is now for prevention of heart failure, especially in those with diabetes and chronic kidney disease. Class 1A indication for the use of DAPA and empagliflozin in patients with kidney disease and diabetes. And again, I mentioned earlier, findrenone, which has now become the drug of choice as a mineralocorticoid receptor antagonist for class 1A indication. So when you have your patients with heart failure or admitted with heart failure with reduced ejection fraction, use all the 4 drugs which we have advised, and you should start them as early as possible, either in the pre-discharge phase or early discharge. In patients who got heart failure with preserved ejection fraction or mildly reduced, then SGLT2 inhibitors also form class 1 indication. And patients who do not have heart failure, but prevention of heart failure also in diabetic patients and chronic kidney disease, the use of SGLT2 inhibitors and the use of finerenone all form class 1 indications. So important to use all these drugs aggressively and earlier. Dr. Mohan has already spoken in detail about the treatment of the iron benefit in terms of hospitalization, but not so much in terms of CV death, etc. But clearly something that we should do, and we need to have a discharge checklist to make sure that we don't forget iron deficiency and treatment of iron deficiency. So key guidelines on this point: SGLT2 inhibitors for patients with heart failure with mildly reduced ejection fraction, dapagliflozin, empagliflozin are recommended, reduces heart failure hospitalization and CV death. In patients with type 2 diabetes and CKD, DAPA and EMPA again recommended, reduce heart failure hospitalization and CV death. Finerenone as a mineralocorticoid receptor antagonist in patients to reduce heart failure hospitalization, those with type 2 diabetes and CKD. Iron supplementation in those with reduced heart failure ejection fraction and mid-range ejection fraction to alleviate symptoms of heart failure and to improve quality of life. And of course, AC inhibitors, ARBs, for patients who have any of these comorbid factors, whether it is diabetes, hypertension, albuminuria, to prevent further deterioration. So these are the guidelines for prevention, etc. Now we know that there are 5 pathways: the angiotensin, norepinephrine, aldosterone, neprilysin, and SGLT2. On the basis of that, we got 4 major drugs: the ARNI, beta blockers, MRAs, and SGLT2 inhibitors. And of course, we also should not forget ivabradine when heart rate is more than 70. That's been proven long time back. Hydralazine nitrate, important in patients, particularly Indian setting, particularly in patients who got renal dysfunction, who got issues where you cannot use ARNI, for example. And then, of course, a lot of work going on vericiguat, which is preferably used for patients who have worsening heart failure. That means those who require increased diuretics or who get hospitalized in spite of the 4 pillars. Vericiguat also has the advantage that it does not produce as much hypotension as ARNI. It also has the advantage it doesn't affect the kidney function, nor does it affect potassium. So it's a particularly useful drug when patients have CKD, hypertension, and potassium issues. Again, of course, having spoken so much about it, we keep coming back to the same issue of patients not being treated adequately. Somehow, we don't seem to be good physicians when we start treating our patients. Dr. Mohan mentioned about LDL and how poorly LDL is controlled when we have so much data on the benefit of LDL reduction. You saw the percentages all in the 20s and 30% of people who reach guideline mandated levels. Same thing is with heart failure as well. A study of almost 16,000 new users, and you can see initiation, very poor initiation. And as you can see from your target dose achieved or discontinuation, look at the discontinuation, the brown bar for dapagliflozin, for ARNI, for ACE inhibitors, for MRAs, beta blockers, and actually target dose achieved in these patients. The dark green is actually the smallest part of the pie circle, except for dapagliflozin, which seems to be much better tolerated. So clearly the important thing in the trial showed that people are not being initiated rapidly enough, they don't achieve enough goals, and the discontinuation is too high. So I think we need to look into that. But I think things are improving. And as you can see from here, as more and more trials are coming out, and I think this is one of the reasons why I think SGLT2 use is much better than some of the other drugs, is because a large number of trials that keep coming up to give us reminders. So as you can see over the last very few years, just the last couple of years, you can see the dramatic increase in terms of use of SGLT2, particularly in patients with heart failure with reduced ejection fraction. But even then, the percentage rate is still 60. It should be 90 or 100. It's still around 60. It's also improving for patients with mid-range ejection fraction and slowly picking up for the use in patients with preserved ejection fraction. So please, important that we should follow these guidelines and try and treat these patients as early as possible. And adequately and for a long time, and not withdraw the drugs unnecessarily. Now, if you look at guidelines of patients with cardiovascular disease and diabetes, as mentioned in the initial talk. Diabetes is such a common problem in our country, and therefore diabetics need to be looked at very aggressively. And if you look at some of the class 1 indications, one, of course, is the diet control. So important to look at diet in patients with heart failure. Again, to prevent atherosclerotic cardiovascular disease in patients with diabetes, we should not look just at the glucose-lowering medications, but look at other factors that can help. And what are the 2 drugs which can help patients with diabetes to prevent future cardiac problems? One is, of course, SGLT2 inhibitors, especially in patients with diabetes and cardiovascular disease, or with a very high risk of cardiovascular events to reduce the cardiovascular. It's a class 1 indication. And of course, GLP-1 agonist, liraglutide, semaglutide, etc. Again, extremely important because we know that they reduce atherosclerosis. Of course, you all know now the tremendous use of semaglutide, especially in patients who are obese and diabetic, because they produce a considerable reduction of weight, which again contributes significantly to the improvement in their diabetic control. And not only that, but significant benefit in terms of cardiovascular events. The recent trial showed benefit of the semaglutide in reduction of cardiovascular events in obese diabetic patients. So clearly, there are a lot of indications which are now class 1 for the use of SGLT2 inhibitors and for GLP-1 receptor agonists for prevention of problems in patients. So diabetic patients must make sure that they are on these drugs, not just for sugar control, but for prevention of future cardiovascular disease. So if you look at the treatment of these patients to reduce heart failure related outcomes in all patients with diabetes, irrespective of what type of heart failure, SGLT2 inhibitors are class 1. I mentioned that earlier. All forms of heart failure preserved, mid-range, and reduced. Class 1 indication SGLT2 inhibitor, empagliflozin or dapagliflozin. And then independent of the A1C, these classes should be used. So clearly, you should not use SGLT only if the sugars are high or not controlled, but it should be as a class 1 indication independent of A1C. Then, of course, you have additional glucose. You can use GLP-1 agonist, you can use sitagliptin, metformins, and of course, insulin. But other global agents increase heart failure. So what are the contraindications? Class 3, that means do not use pioglitazone and saxagliptin. So do not use pioglitazone, saxagliptin. Always use SGLT2 inhibitors, use GLP-1 for their atherosclerotic reduction, and of course, insulin, metformin, etc. for the control of diabetes and its other benefits. So key messages: diabetes is diagnosed based on A1C and fasting blood sugar. SGLT2 inhibitors with proven CV benefits are recommended as class 1 indications to reduce cardiovascular events. Statins, of course, in all diabetic patients, statins should be used to reduce LDL cholesterol. If statins don't achieve the guidelines, early use of ezetimibe, PCSK9 inhibitors. Of course, we have bempedoic acid as well now. So clearly, control of lipid therapy is extremely important. So diabetic patients, early use of SGLT2, early use of statins, ezetimibe, and if necessary, PCSK9 inhibitors. Also in diabetic patients, do a very careful check of the regular blood pressure. Make sure the blood pressure is below 142 by 90, and better still 130 in younger patients. Aspirin may be used in patients with previous cardiovascular disease. In patients with diabetes and ACS who undergo PCI, a P2Y inhibitor with aspirin should be maintained for 12 months. So in a month, one of the suggestions is, of course, that longer-term therapy rather than closing the therapy and reducing to single dose should be a bit more care in patients with ACS and diabetes. Of course, you can use clopidogrel when aspirin is intolerant. And as I've already mentioned to you, there are studies even to suggest that in spite of not being intolerant to aspirin, clopidogrel may possibly be a better drug. And of course, in patients with atrial fibrillation, important to use NOACs rather than PKA. Shortening or scaling down DAP to clopidogrel should be avoided in patients with diabetes post-ACS, given the high background risk and the lack of efficacy data in these patients. It is recommended to assess glycemic status at initial evaluation in all patients with ACS. So clearly, glycemic control and treatment, as I mentioned with SGLT2 inhibitors in all these patients. Monitor and keep glucose well under control, and of course, use e-health applications to improve adherence both to lifestyle interventions and to drug therapies. Moving on to the acute coronary syndromes and management of ACS. Well, they call this nice ACS. One is abnormal ECG, one is clinical context of the patient, and patient to be evaluated whether the patient is stable or not. Patient presents to you, these are the basic things, of course, that we would all do. Having done the basic things, what do we do next? We think of invasive management. When do we think of invasive management? One, when the patient has STEMI, in which case you think of primary PCI, if not possible, fibrinolysis. In patients with very high risk, non-ST elevation, immediate angiography and SOS plasty is indicated. In patients with high risk, non-ST elevation, you should do an angiography within the first 24 hours. So think invasive management in these patients. Antithrombotic, very important, aspirin, P2Y inhibitor, anticoagulation, low molecular weight heparin or enoxaparin or whatever as a part of the therapy along with STEMI or fibrinolysis. Think revascularization, again, based on the clinical status of the patient, whether the patient has comorbidities or not, so PCI versus CABG, and aim for complete revascularization. Again, a lot of data suggesting better to do complete revascularization rather than only target vessel. And of course, adjunctive therapy, may need imaging and other things to make a decision. And most important, of course, in all patients, think of secondary prevention. So antithrombotic therapy to continue, lipid lowering therapy, stop smoking, cardiac rehabilitation. Please do not forget, this should be also on your heart failure checklist or ACS checklist, cardiac rehabilitation for all patients, risk factor management, and don't forget again, psychological considerations. Myocardial infarction is a traumatic event in a person's life. Psychological evaluation also required to be done. In patients who present with ACS in the casualty, how do you triage them? Of course, as I mentioned, ECG, physical examination, clinical history, vital signs, the ACS, as I mentioned. And of course, we all know that troponins are extremely important in evaluation if the patient doesn't have significant ECG changes. Then again, ST elevation, the patient should go for immediate angiography, PCI or fibrinolysis, depending on availability of PCI. Non-ST elevated, again, PCI, non-ST elevated without very high risk factors. Again, they do need an angiography, but the urgency is much less compared to the others. Invasive investigations, of course, angiography, echocardiography, intravascular imaging, also a part of your treatment and future management of these patients, as I mentioned. So again, looking at this algorithm for multivessel coronary artery disease, patients with ACS undergoing PCI for infarct-related artery and angiographically significant stenosis, more than one in a non-infarct-related, the patients in cardiogenic shock, then immediate PCI of the infarct-related artery class 1 indication, stage complete revascularization class 2B. Patients with STEMI, complete cardiovascular revascularization either at the index or within the next month or so, class 1 indication. Non-STEMI ACS, complete revascularization class 2B, functional evaluation of the non-culprit vessel class 2B. So clearly, I think the guidelines have been not significantly changed and we have been following them. If patients need fibrinolytic therapy, which we know in India is still a very important thing, class 1 indication, of course, to start fibrinolytic therapy as soon as possible, preferably to use tenecteplase or retiplase as a fibrin-specific class 1 indication. And of course, patients over 75 use half-dose tenecteplase. Aspirin and clopidogrel are recommended class 1 with any patient undergoing fibrinolysis, and of course, anticoagulation along with fibrinolysis, usually enoxaparin IV followed by subcute. Again, not really very much changes or anything new in this particular guideline. So just to look at some of the key messages again, emergency perfusion, reperfusion triage should be done. Early ECG within 10 minutes of first medical contact. All STEMI patients with ST elevation or equivalence within the first 12 hours of symptoms must undergo reperfusion therapy. If PCI time is going to be less than 130 from diagnosis, PCI pharmacoinvasive therapy, in case the time is going to be long. And after fibrinolysis, transfer all patients to have an angiography within the next 2 to 24 hours. High-risk patients with non-STEMI, again, recommended invasive therapy. If the patient is suspected of unstable angina, you're not sure what you're dealing with, again, invasive therapy. In non-high risk, non-STEMI patients, a selective invasive approach may be done. Of course, aspirin, clopidogrel, prasugrel, nothing changes as far as that is concerned. Again, they strongly advise proton pump inhibitors, especially if you are using combined dual antiplatelet therapy to reduce GI bleed. Single antiplatelet therapy, proton pump inhibitors are plus minus, but dual antiplatelet therapy, important to give proton pump inhibitors. In ACS patients, anticoagulate all the patients. Fibrinolysis should be started as soon as possible. Anticoagulate with fibrinolysis till the patient undergoes an angiography. Enoxaparin has been the preferred low molecular weight heparin. Beta blockers recommended for ACS patients with ejection fraction less than 40%, regardless of heart failure symptoms. Angiotensin AC inhibitors recommended for ACS patients with heart failure symptoms, EF less than 40, or diabetics, hypertension, or CKD patients. And again, mineralocorticoid receptor antagonists, ACS with heart failure, ejection fraction less than 40%, and heart failure or diabetes. So I think we've covered up some ground in terms of dual antiplatelet therapies, endocarditis, heart failure, and ACS. There are some interesting points and some, of course, nothing new. But I think the important point I would like to make is that we need to be a little more aggressive with our management. As Dr. Mohan also mentioned, early treatment is important. So whether you have treating lipids or you're using antiplatelets or using fibrinolysis or PCI, early treatment is very important. Follow the guidelines, use all the drugs as early as possible. Don't unnecessarily stop the drugs. And I think that it's still shameful that whether it's ESC 2018, 19, 20, or 23, we still keep talking about less than 30, 40% of our patients being on drugs. So I don't know why we have these meetings, why we have these guidelines when we don't continue to follow these guidelines in spite of so much evidence that they benefit. You have a drug like PCSK9 and other drugs which can reduce your LDL and actually cause plaque regression, and yet we allow our LDLs to remain at 70 and 80. We have heart failure patients who can dramatically improve their ejection fraction, reduce their mortality with all the drugs, and yet only 30% of the patients are on this drug. So there is something wrong in this inertia that we have, and we need to correct that. Thank you very much indeed.
Thank you very much, dear sir. In fact, I must say thank you, dear sirs, for an astute oration from either end. And we are very sure that the audience has been very gripped looking at the questions that have come to us. With the permission of our esteemed speakers, can we move over to the audience Q&A?
Yes.
Sirs. The first question is from Dr. Patel. So Dr. Patel asks, in heart failure with mid-range ejection fraction, SGLT2 inhibitors, that is dapagliflozin and empagliflozin, have a class 1 indication, while ARNI, MRA, beta blockers have a class 2B indication. Is there any chance that any of these other three agents may ascend in the level of evidence in future? If so, which of them seems promising?
I think in patients with mildly reduced ejection fraction and even preserved ejection fraction, most of us agree that mineralocorticoid receptor antagonists are important drugs. Right from the beginning, these drugs have shown to be beneficial, and at least I, and I'm sure Dr. Mohan also uses a mineralocorticoid receptor antagonist in this group of patients. As far as ARNI is concerned, ARNI never came out very well with benefit in terms of anything except reduced ejection fraction. There has been some benefit in the mid-range ejection fraction in female patients, etc. And there is more and more tendency towards using ARNI even with mildly reduced ejection fraction. Not much evidence about ARNI in preserved ejection fraction. Now, there's, of course, the advantage of SGLT2 inhibitors reaching class 1 is because if you look at the number of trials with SGLT2 inhibitors, both DAPA and EMPA, in such a large variety of patients, that it obviously has much more data compared to ARNI, where there's very limited data when you talk of mid-range and preserved ejection fraction. So that's why I think it's class 1 now. As more trials come out, maybe it will change. Dr. Mohan, do you use ARNI and MRIs in, say...
I think MRA I quite often use, and I think I am personally convinced that the lower end of the spectrum of ejection fraction, I am more inclined towards using ARNI as well as MRA. However, when the ejection fraction is much higher, above 60%, ventricles are small, hypertrophied, elderly female, I probably would stay away from them. So I actually, since I'm an imager, I actually look at the left ventricle and left atrium. If that looks to me more like, despite ejection fraction, more like HFrEF, I would use it. But having said that, I make a decision on a case-to-case basis, largely based upon the kind of ventricle it looks to me on echocardiogram.
Noted, sir. The next question is from Dr. Hitesh. Dr. Hitesh says, he greets both of you. He says, Namaste, sirs. Should we use, I think the message has been very clear from your end that no one statin is better than the other, but Dr. Hitesh asks, should we use rosuvastatin over atorvastatin for ASCVD or MI patients? And he also puts forth a question based on the evidence that was shown by Dr. Mohan, the Lodestar trial, which also raises new questions on rosuvastatin due to its adverse effect on cataract. So he's just asking your views, just a reiteration of the same, sir. Over to you.
So you know, good time back, I think it is about a decade back, we had this study called Planet 1 and Planet 2, comparing rosuvastatin with atorvastatin. And we did realize that rosuvastatin and rosuvastatin was a little better than atorvastatin, but there were more tubular proteinuria with rosuvastatin. And that was trying to put a spanner in the wheel, thinking maybe we should use more often atorvastatin. Another reason which actually came up was atorvastatin being lipophilic, and of course, there's a lot of cholesterol synthesis within the cells. Maybe atorvastatin, even if it does not affect the LDL cholesterol, which is circulating at the tissue level, probably in the cellular level, maybe it will do better. But I think these are all theories. With regard to Lodestar, with a little more cataract and a little more new onset diabetes, I think these are some of the minor penalties you get when you have a more powerful drug like rosuvastatin. Clearly in Lodestar, 62% patients with rosuvastatin achieved a level below 70 against 55% with atorvastatin high intensity. Obviously, a more powerful drug probably has a more diabetogenic effect. With regard to cataract, it came to me as a surprise, actually. But remember, there are a lot of these things which we don't understand. Why cataract should be more often? Why with the actually canagliflozin you had initially seen more fractures and then you could not show it in credence. Similarly, we still keep thinking why with bempedoic acid there is tendon rupture. Can we explain it? I say it's a tough thing actually to explain. So some of these things will always be there. There would be odd things which actually would attract you. But by and large, if I am a cardiologist, I would place rosuvastatin high intensity versus atorvastatin at same pedestal.
Yeah, I think it's important to remember that if you have an ACS or you have coronary artery disease and you don't take your cholesterol medicines and reduce your LDL, you won't get old enough to develop cataracts. So those who live longer get more cataracts. So it's better to live longer and have cataracts changed rather than to die early with normal lenses.
That's true.
Point very well taken, sir. The third question is from Dr. Anand. Dr. Anand asks, low-dose aspirin for a primary prevention strategy, whom and where, and probably whom to avoid?
Well, this use of aspirin primary prophylaxis has been there for years. I mean, everybody in USA used to take baby aspirin for donkey's years. Then, of course, I think about 4 separate trials came about 4 years ago. Again, most of them presented at the ESC, suggesting that aspirin as a primary prophylaxis was effective, no doubt, but it produced far more bleeding. So therefore, in the risk-benefit ratio, aspirin produced more harm than good. And therefore, the present suggestion and guidelines is not to use aspirin as a general prophylaxis for all people. So now, which patients would you use aspirin? Even I'm particularly confused at the moment as to when to use aspirin as a primary prophylaxis. The question number 1. should all diabetics be given aspirin or not? But I just read the guidelines to you just now, which said that it was not necessary to use aspirin as a prophylaxis for all diabetic patients unless they had a high risk for future CV events. So I think it comes back to finding out your risk profile for cardiovascular events. If you have diabetes plus a high risk profile for cardiovascular events, then you should use aspirin. If not, then you should not use even for diabetic patients. Then the question comes of patients with, then when should you use aspirin? Well, obviously, if a patient has got cardiovascular disease, there is no question that it's not a primary prevention, you use it. Now, the question is, when you have a patient with a CT angiography showing 60%, 50% lesions, and he has not got an event, so does he become a person with problems or without problems, and should you give aspirin or not? I've not been able to find an answer to that. I think everybody agrees that statins are important in this subset of patients. And again, whether I would use aspirin or not in a patient with a 50% CT scan asymptomatic is debatable. I think if he has other issues, like for example, if he is a diabetic, hypertension, strong family history of heart disease, and though he's asymptomatic without any event, but CT scan shows atherosclerosis, I might use aspirin. But if he's a low-risk patient and no other reason, then I would not use aspirin. So to shorten my answer, primary use of aspirin for all patients, no. Certain subset of patients, diabetic with high risk, etc., yes, you may consider so. Again, Mohan, your opinion, because I think it's no answer.
So absolutely, I completely agree with you. We have seen actually the aspirin primary prevention for last 30 years, large number of trials. I was only yesterday looking at David Capadonna's review article. He talked about all those trials, POPA-DAD, JPAD, PPP, but the three large trials are ARRIVE, ASCEND, and ESPRIT. And within these three trials, you have more than 50,000 patients. And all these three trials are telling you one thing. You put all three trials together, elderly individuals or diabetic individuals or high-risk individuals, aspirin has no effect on primary prevention. Bleeding is more by 30%. The only positive trial between the two are ASCEND trial. ASCEND trial had 15,000 patients. Jane Armstrong presented this data actually in ESC, one of those ESCs with me and Jimmy were also there. 15,000 patients, 7 years follow-up, 100 milligram aspirin versus placebo, and 3/4 of these patients were already on statin. There was a 12% reduction in primary events, which was actually trumped by a 29% increase in major bleeding. End result, if you want to calculate number need to treat in diabetics, mean is 65 years diabetic, you want to help a patient, you have to treat actually 331 patients to prevent one major vascular event, 330. And what is the chance of producing major bleeding? You just have to treat 111 patients to cause one major bleeding. So the odds are so much against aspirin for primary prevention. The ESPRIT trial, actually ESPRIT trial in elderly people, just a month back, ESPRIT actually published primary prevention of stroke with the low dose aspirin in elderly people in JAMA network. Absolutely no benefit with regard to ischemic stroke prevention. On the other hand, hemorrhagic stroke increased by 40%. No effect on ischemic stroke in elderly people. 38% increase in hemorrhagic stroke. Who wants aspirin actually? If I am 70 years old, do I want to take aspirin if I don't have atherosclerotic cardiovascular disease, manifest atherosclerosis? As Jimmy rightly said, if somebody has calcium score, where is the data? We just don't have data actually. Where are the data which says that I have a calcium score of 100 and I should be given aspirin that I would benefit? Has somebody done a trial? There is no trial. So the guidelines are given it a class 2B/C indication, consensus, and maybe it will benefit. Maybe it will benefit.
But I think what's more worrying, Mohan, is that I see a lot of people, doctors starting dual antiplatelet combination therapy for non-significant patients who don't require even a single antiplatelet. I think that is something we need to stop. Dual antiplatelet therapy will increase your bleeding much, much more than just aspirin alone. So just randomly writing this combination of dual antiplatelet therapy without giving thought, please don't do that.
So we have this major issue. Largely, this is done at the physician level. and family physician levels. And I think our greater emphasis on education should be for these individuals. Those who practice from morning 8 o'clock till midnight and of course don't have time to attend webinars or get the message, we need to tell these people that dual antiplatelet, somebody had a migraine like TIA and you're giving dual antiplatelet lifelong to a young 27-year female is not a great idea actually. And I keep seeing every day. So Jimmy, you're right, absolutely.
So the next question comes from Dr. Paresh. Dr. Paresh, thanks you for discussing on the strong HF trial and the fact of up-titration of GDMT within 6 weeks. However, he asks, a small challenge in his clinical practice tends to be the increased risk of hyperkalemia, especially when ARNI and MRA are up-titrated almost closely at the same time. Any clinical tips and tricks while escalating them?
No, I think we have discussed this thing multiple times. Hyperkalemia would occur in 10 to 15% people whenever you are combining ARNI and MRA, more so in individuals who have lower EGFR. So if the EGFR is more towards 40s or maybe 30s, start one at a time, wait for potassium to stabilize, and then add MRA or reverse the thing. But much more important now with the fine art study, data probably would come and finerenone may replace eplerenone and spironolactone in a big way. The third issue, of course, is frequent monitoring of potassium is required. We also have to understand that 15% of patients with CKD, with or without diabetes, actually have potassium losing nephropathy along with. These are the patients where MRA can be given easily, ARNI can be given. So decision would have to be taken on a case-to-case basis. However, I do not recommend at the moment using a potassium binding resin just to keep the potassium low because that has colonic implications. But this is an issue, and we know that in all randomized trials, the maximum use of MRA is 70%, which means you would not be able to give 30% patient MRA of heart failure. Multiple reasons, CKD, potassium, all this, and we have to accept it. What can you do for them? You have multiple options actually. You could think of giving Vericiguat. You can think of, as Jimmy said, hydrazine and isosorbate nitrite combination. You can think of even with the digitoxin, again making a resurgence and not metabolized, is not excreted through kidney, maybe that would come. The data is going on. Maybe next year we'll have a study on digitoxin and heart failure. Multiple ways of, these are random thoughts which come to my mind actually.
Yeah, I think like one good thing is that the SGLT2 inhibitors don't produce help the hyperkalemia. So SGLT2 itself will help. Finerenone, as mentioned, probably produces less hyperkalemia than the other one. So that might be a great advantage. And again, use small doses. So if you're worried about it, don't use full doses of mineralocorticoids. Maybe use a smaller dose. But I think, yeah, potassium is a problem in practical sense. There's no doubt about that.
Thank you, sir. So Dr. Shushant asks, a wonderful point discussed by you, sir, he means you, Dalal, sir. So was that when discussing for the management of ACS and discussing secondary prevention of the same, you were discussing about the important role of smoking cessation. So Dr. Shushant writes, in India, clinicians commonly use nicotine replacement therapy, which may be deleterious to cardiac patients. So should we consider newer agents like varenicline in such patient populations? Or are there any other agents available, or what can be done?
Sorry, Mohan, would you like to take that question? I don't have
I'm no expert on that. I have to agree. I have no idea about de-addiction with the nicotine or smoking. I know the nicotine patch have been used, but I only know, first thing, they're expensive. Second, there's poor adherence. And third, they don't work in 50% of the individual. That's all I know about nicotine patch. I don't know anything more than that.
Noted, sir. So in that case, we go to the last two questions for the day. Sir, Dr. Narendra asks, Sir, is there any specific risk scoring system that can be used for us Indians? Or if there is no risk scoring system, how should we delineate patients as high risk, mid risk, low risk?
Mohan, take that question. You
Yeah,
talk
okay.
about
Okay.
yeah.
So let me just talk to you about the 4th National Family Health Survey conducted in India in 32 states involving 780,000 adult males and females. Based on the Framingham risk score, the entire country was colored based on the risk, barring few pockets. And the red, deep red is high risk, red is very high risk, red is high risk, and yellow is moderate risk. And of course, green is no risk. Throughout the country in adults, there were no green risk, there were no green area. Very few yellow areas for females. Most were red and deep red, Framingham score. So forget about finding actually a score system for India, multiplying Framingham score by 1.5 to 1.3 as or a WHO score. The fact is that Indian adult population is, most of it is moderate to high risk. The same thing is available from Sentinel study. Now, but you still want to use a risk score. I think the Q risk 2 is nearer to truth because the Britishers have tried to validate it. The UK Biobank data, which actually they brought out, Amit Khera actually brought out, Amit Khera brought out that 2 years back. Very interesting data. They tried to look at Caucasians, age, gender match, and of course the South Asians. For India, you could multiply any risk score by 1.8, which people have validated. For Pakistan, it is slightly more, 2.4. For Bangladesh, also it is 2.4. For Nepal, I think it's same as India. You could use multiple different ways. What do? I usually use a Q risk score too. That is what I do.
Thank you,
but
sir.
I would also say that use a common risk score, common sense risk score. So don't always keep looking at the score. Actually, use a common. Look at the common sense. Actually, with the 35% of the Indian population having hypertension, 11% having diabetes, and obesity being there in 29%, dyslipidemia in 83%. There's a data which was published by, as you said, ICMR study, June 7 in Lancet. They're just 2 months old data actually. So what are you, 29.6% obesity, 35.5% hypertension, 11.4% diabetes, 80% dyslipidemia. We are entirely we are risk-laden population actually. You could use common sense, whether you have 2 of them, 4 of them, 3 of them, and then you can say, where are you standing actually?
I think I agree with Dr. Mohan completely. Just use common sense. People often ask me, do I use scores? I don't take out little charts and start measuring scores. You talk to the patient for 5 minutes and you have enough experience to make out the score of the patient pretty quickly. Yeah. So I think you can really make it out quite fast as to what the patient's risk is. Just need to talk to them and ask a few questions.
So the last question of the day. So Dr. Kunal asks, diabetes guidelines have over time embraced CV risk and renal risk with drugs like GLP-1RA and SGLT2 inhibitors. In the future, will we probably get to see hepatic outcome data too for NASH? Your take on the same, sir.
I'm sorry, I didn't get the question.
So what Dr. Kunal asks is, with diabetes guidelines, we tend to see that they have embraced CV risk reduction and renal risk reduction also with the ADA guidelines. So what he's asking is, in the future, considering that we have a huge burden of non-alcoholic fatty liver disease too, should that also be probably taken into consideration in patients?
Probably it will come sometimes. We know that kidney and renal as cardio-renal is a very common thing. The cardio liver is not as common as cardio-renal. But I think with all this non-fatty fatty liver and non-alcoholic fatty liver and its role and how important it is, but somehow we haven't seen too much data about lipid-reducing agents producing dramatic benefits for fatty liver. So neither is there data about too much about SGLT2. So I think we still haven't come to any great therapeutic utility of either lipid lowering or SGLT2 inhibitors for fatty liver, etc. But I think fatty liver is a problem which we'll have to consider in the future, and the issue of fatty liver with heart. Mohan, your thoughts on that about how do you deal with this fatty liver issue, which is an epidemic now?
So day before yesterday, actually, I was in Lai meeting actually, and there were 5-6 international speakers. So few facts which I learned. 80% of the diabetics in India, of course, have what you call non-alcoholic fatty liver disease, which now has been termed MAS LD, metabolism associated steatotic liver disease, MAS LD. 80% diabetics have it. Number two, amongst non-diabetic, 38% Indians have this so-called MAS LD. Lean Indians have 25% of lean Indians with a body mass index of less than 23 have so-called non-alcoholic fatty liver disease. Some facts, important facts. Drugs, what drugs we have got. So if 80% of the diabetic have it, which means actually every diabetic has it. You know, it's like every diabetic having dyslipidemia. You just have to find a great drug for it. GLP-1 analogs or dual incretins or triple incretins are the only ones which are showing promise. Saroglitazar is approved in India. How much data? There is some data, but the data is not persuasive enough. With SGLT2 inhibitors, the data came, but it was single-centered, small. It was not placebo-controlled. It was not multicentric with a core lab. People actually did not accept the data. The only thing which has a future is probably GLP analogs and the GLP and GIP analogs, and I would say triple incretins and dual incretins. But at the moment, there is no approved drug for MAS LD or NASH or non-alcoholic fatty liver. No approved drug. In USA, there is no approved drug. In India, of course, saroglitazar has been approved. Why? We don't know actually.
Thank you, sir. Thank you so much for that, for each of those answers. And we are very sure that the audience which has attended, which is so carefully attended, even to ask these level of questions across, which shows the audience has been very interactive. And we're very sure that they have learned from this webinar. And we are very sure that the learnings will ultimately improvise their patient care outcomes. I now hand over to Mr. Robin Gulati to give the vote of thanks to both of our esteemed gurus, to both of our esteemed speakers. Over to you, Mr. Gulati.
Yeah, thank you, Dr. Parthasarathy, and thank you so much. I extend my, deep-hearted thanks to both our eminent speakers, Dr. J. Simon sir and Dr. Jamshed Dalal sir, for giving their precious time to us and enlightening everyone. Almost to give you the updated figures, we have more than 2,000 live audience watching us at the moment, and I'm sure they would be really glad to have the insights what you have given us in this 1.5 hour session from the 4 days of conferences which has happened this last week. And we just thought at Macleods that what other day could be the best day rather than the Teachers' Day to have two best teachers from our country to educate the entire medical fraternity on the updates from the European Society of Cardiology. We're glad that the audience has joined us. For all those who have joined us late, you can view the recorded session on our YouTube channel, CV Live. You can subscribe the channel, follow it, and click the notification icon for all future events we conduct on our YouTube channel live. So once again, thank you so much from the entire Macleods team to all our panelists and to the audience, especially who have made this event a very successful one today. So we will definitely see you with a lot of good stuff in the future as well from more on the scientific updates. Thank you so much. Have a great evening and take good care of yourselves, everyone. Thank you.
Thank you. Thank you.
Thank you.